But see, a limit of internal rotation, but let's see the external rotation. It was just until 0. She had nothing more than 0, okay? Yeah, I'm showing it again. Abduction, it was not bad. Okay, she didn't have full elevation because of scary tissue in the inferior part of the capsule. But see, 0, absolutely nothing. And that was lacking her life too much. So this is the arthroscopy. This is a left shoulder. I am establishing the portal with a spinal needle. It's very tight, so you don't use an cannula, okay? It's a lot of scary tissue, so you establish it with spinal needle. You enter with a straight artery forceps. So, and then ask your assistant to open the capsule with 2 hands, not 1, 2, a lot of strength to make a pass to enter with the instrument. So you start with a shaver, okay, and you go, don't go medially, don't go laterally. I don't want to hurt the cuff. I just want to establish a view in this very, very thick space. In this case, it was very easy to find the sutures of the biceps tenodesis that I had done 18 months before. And the thing is, I didn't have to look for that. It would be difficult to identify the biceps tenodesis in such a big amount of fibrotic tissue. So I just saw that. I didn't have to mess with that. The surgery is just in front of me. It's this wall of fibrotic tissue that is below the biceps. In this case, it was already tenodesis, okay, and it's just above the subscap. So what are we going to do now? I'm going to start the surgery, establishing a view just above the subscap, just below the capsule. I am seeing now the anchor of the biceps from which I did the tenotomy 1.5 years before. Okay, I'm just removing some scary tissue just to establish a view. Now I'm going to show you a picture of the biceps tenotomy. You can do it in the left with a basket or with other instruments. This is a very, very important image. Okay, so here we see a path that I have created above the subscap, below the capsule. This big wall of fibrotic tissue, I'm going to have to take it off. This is what the surgery is about. So this is the subscap, the upper part of the subscap. Let's understand slowly anatomy. This is the anterior capsule that I really want to take off, like the letter U. Okay, like a letter U. Here on the left side, I have the humeral head. This is the left shoulder. On the right side, I have glenoid and the anterior labrum. Okay, so we must really know what we are doing in terms of anatomy. Okay, so what are the steps? I'm going to show you a lot of tips. So first of all, what you can do in this case is after you define an entry, is to enter with the radio frequency device. I am using again the artery forceps open with 2 hands. Okay, this is a very tight tissue. So now I'm going to start entering with electrocautery or radio frequency device. This is extremely important because I want to divide this big wall in 2 parts, medial and lateral. So I am diminishing the thickness, okay, of this big wall in the of fibrotic tissue in a way that I can finally enter with the arthroscopic scissor. This is a very important instrument in this surgery. I want to split this big wall in the anterior capsule, in the rotator interval in between 2. You see the biceps tenodesis on the left. I must do it until I see the anterior part of the deltoid, which is obviously this red muscle in front of me. So I do it upon, and my intention is to divide the capsule in 2 parts. In that way, I can start debriding it medially and laterally. I do it with the shaver. It's not difficult once you divide it in 2 pieces. This is very important. I don't want blood. I don't want any bleeding space here, points, to avoid more fibrotic tissue. These patients, they don't use a sling. They go to immediate motion on the second after surgery. So I don't want any bleeding. So this is the anterior labrum. The surgery is almost done. So what are we seeing here? This is a very pedagogical image. What are we seeing here? This is a left shoulder. I'm going to show you slowly all of the anatomical structures. Everything in medicine, in orthopedic, in surgery is anatomy. Anatomy is super important, everybody knows. So what are we seeing here? First of all, here on the left side, we are seeing the cartilage of the humeral head. Okay? This is what we are seeing now. I'm going to show you very slowly. It's coming out. This is the humeral head. Okay? So see, this is a left shoulder I'm mentioning for posterior portal. This is the subscap, which was in a very nice status. I'm going to show you no tears, just some fraying. I'm going to show you what I did with it. Okay? And on my right side, I see the anterior labrum together with the root of the biceps, from which I did the previous tenotomy, and the anterior labrum. Okay? And in front of us, what we are seeing the anterior deltoid. So we are seeing the anterior deltoid, and I must see all of this in the end of the surgery, which is not a long surgery, okay? You can do it in 15 minutes. I was telling you, this is a letter U. This is what the surgery is about. You must create this letter U in a way that you remove all of the strong wall. And after that, immediately what you must do is not to forget that there are some adhesions in the articular part of the subscap. So what I'm going to do now, this is the anterior deltoid. You must not forget the adhesions in between the articular part of the subscap and the anterior part of the glenoid. But you must have a lot of care not to create, pay attention, any iatrogenical Bankart tear. So what I'm going to do now, so see, this is the subscap. I am developing a plane between the subscap and the anteroinferior glenohumeral ligament. I must be extremely delicate because I don't want to create an iatrogenical Bankart lesion. This is so you see. I see the anteroinferior glenohumeral ligament, the subscap. I just want to free the adhesions. It's very important to do after that a MUA. This is a MUA, manipulation under anesthesia. Immediately you gain all of the external rotation you need. It's amazing. Okay, so still, I am a shoulder surgeon. I do a lot of cuffs, so I saw this fraying in the upper part of the subscap. This is not a tear, but I was afraid that this could be a tear, I would say, in the future. So what I did, and I did in this case that I have done today, is low temperature ablation of the fibers. So this is what I'm doing now. I put the electrocautery. Now it was in high temperature, and then I diminished that. So I am making an ablation of all of this fraying, okay? Just in my point of view, to diminish the chance of having a subscap tears, I would say, in some years in the future. Okay, I think that it makes sense. So, so this is the final result. This is the ablation of the subscap. Okay, this is all of the tissue that I removed. Immediately after the surgery, you have a tremendous change in the motion. So I'm going to show you now how was the patient 1 minute after we closed the skin. So let's see now, what about external rotation? Full, just like the other side, okay? Something about 60 or 70 degrees. Forward elevation was better because we removed the adhesions of the anteroinferior capsule. So now it's normal, okay? And what we do with these cases, we never put a sling. I always ask them to move immediately, okay? And the final and the clinical results, I would tell you, in 15 days are amazing. And as a rule, these patients, they disappear from